for joining us, please.
Hello, everyone. My name is Charles Huskins, and I'm a professor of pediatrics at the Mayo Clinic College of Medicine and Science. I'm also the chair of the Division of Pediatric Infectious Disease at Mayo Clinic. Thank you very much to the conference organizers for inviting me to be a part of your conference and to give this presentation. And thanks to you, the audience, for your attention and your interest in my presentation. Give me just a moment while I pull up the PowerPoint presentation. So I'd like to start with some greetings from Southeast Minnesota. You see on the slide some artwork in the middle from our Mayo Clinic Children's Center. And what it shows you is the rolling hills of southeastern Minnesota covered by agricultural fields of corn and soybeans, as well as forest and our lovely paper birch trees in the foreground. So this is some art that children can enjoy in our Children's Center. It was my great hope that I could visit Dubai and meet you directly and see your beautiful city and surrounding areas for myself. Unfortunately, the pandemic did not allow that this year. Nonetheless, I hope that I can visit your city and hospitals in the future in person. My presentation today is titled Approach to Recurrent Fever in Children. It will focus on a diagnostic approach to fever rather than a treatment approach, because obviously treatment may vary tremendously depending upon what the actual diagnosis is. I recognize that diagnostic approaches vary by geographic location depending upon the diseases common to the area and according to the setting in which the patient is seen, be it a clinic, emergency department, or tertiary care hospital. My description of an approach that we use in Rochester, I think works reasonably well here, but I recognize other approaches may be needed in other areas, including Dubai. My objectives for the presentation are the following. First of all, to describe an approach for classifying fever episodes in children. Second, to identify key features of recurrent fever versus conditions in which fever is prominent, but not necessarily recurrent as a primary feature. Third, to compare and contrast periodic fever syndromes in terms of their characteristics and how they are diagnosed. I've tried to design both the format and content of my presentation to really highlight this compare and contrast what's similar, what's different between various periodic fever syndromes in order to help characterize them more effectively. So virtually every meeting that we have with a patient and with a family, especially in relation to recurrent fever, involves some discussion of what is actually a normal temperature and what constitutes fever. Normal temperature is, of course, plus or minus 37 degrees centigrade, but can vary by several factors, including age. Younger children, or very young children, can have a slightly higher temperature, in part because of their larger body surface area and somewhat higher metabolic rate. Of course, the site at which you measure the temperature, the body site, can affect the temperature. A core temperature, for instance, taken in the rectum is going to be higher than either oral or axillary sites of measurement. Time of day is very important because temperatures often are higher in the late afternoon than they are in the early morning. Physical activity and metabolic activity can also raise temperature. Metabolic activity including eating meals and things like that. And then phase of the menstrual cycle, we know that there can be some elevation in temperature around the time of ovulation. So what constitutes fever? And what I will show you here are some definitions that we use in the United States and in relation to age. So for infants less than 3 months, we prefer to measure temperature by the rectal route. And a fever also constitutes a fever of concern representing a higher fever or temperature, but also a higher level of concern about what may be causing that temperature. So for less than 3 months of age, it's greater than or equal to 38 degrees centigrade. For children 3 to 36 months of age, again, rectal temperature preferred, and fever would constitute a temperature equal to or greater than 38.0 to 38.9, with a fever of concern being equal to or greater to 39.0. And greater than 36 months of age, oral tympanic membrane or axillary temperatures are often used, and a fever would represent a temperature equal to or greater than 37.8 to 39.4, with a fever of concern at 39.5 or greater. The fever of concern is helpful as we start to then categorize febrile episodes a bit more, which we'll do on this slide. So we begin with what in the US we call fever without source. And that usually involves a fever of concern, so a higher level of temperature, for usually less than a week. There's no diagnosis after a thorough history and physical. We presume that this is most likely due to infection. Sometimes that can be diagnosed clinically. Other times, some basic laboratory tests may be performed like a CBC, urine analysis, maybe a blood culture, urine culture, with or without a chest X-ray if there's respiratory symptoms, and lumbar puncture to examine the CSF based on young age, and certainly if there's any signs or symptoms that raise concern about CNS infection. And the goal here is to see if we can identify a childhood infection, and especially identify a serious treatable infection, because we want to address that directly. A second category is fever of undetermined origin. There's various definitions for this. I tend to use this one here, which is a fever which is not necessarily as high as a fever of concern, but a temperature of 38.3 or higher, and occurring once a day or nearly once a day, and for a longer period of time, greater than or equal to 8 days. Again, there's no diagnosis after a history and physical exam. Basic laboratory studies may have already been performed, but if they haven't, they should be at this point in time. And then imaging studies as indicated, with the goal again to identify a diagnosis, but in particular to exclude a treatable infection. Other steps at this point are to then consider less common and particularly serious or other infections that are at least explanatory in terms of the episode, and then also begin to consider the possibility of oncologic, inflammatory, or other conditions as the cause of the fever. Now, over on the right side, we then have recurrent fever, which is a different type of fever, not necessarily in its measurement, but in its pattern. So this is fever that's present for at least several days, with intervening periods, usually with no fever, and variable levels of wellness at that point in time, including sometimes situations where the child can appear entirely well. These fever episodes tend to recur over months or years, and we don't typically regard something as recurrent fever until it's been going on at least for 6 months or so. The goal here is to identify an underlying condition that may not be recognized yet, and to differentiate recurrent fevers due to recurrent infections from other causes of recurrent fever. Now, as an infectious disease physician, as I start to consider patients with a fever of unknown origin or recurrent fever, one of the first things I have to do is to consider the possibilities that there is an infection that has not yet been diagnosed. And as I go about doing that, I think first in the realm of, what are the classes of infectious agents that can do this? And certainly respiratory and GI viruses can cause fever, but not usually in the realm of what I just defined as an FUO or recurrent fever. Viruses that can certainly cause fever of undetermined origin include CMV, EBV, adenovirus, enterovirus, hepatitis viruses. Bartonella or cat scratch disease is another entity that can certainly cause a prolonged and recurrent fever. Another major category is the arthropod-borne infections. RMSF is Rocky Mountain spotted fever in the US, but there's another category of Borrelia caused infections that are relapsing fevers. Those are either the tick-borne relapsing fever or louse-borne relapsing fever. And then more recently recognized is the Borrelia miyamotoi as, again, another cause of Borrelia-associated fever. In the Midwest and Southwest United States, we consider the possibility of endemic fungi as a cause of fever. And then many of the diseases that you see listed here, which are considerations worldwide, including HIV, malaria, Salmonella, TB, brucellosis, which I know you're quite familiar with, leptospirosis, toxoplasmosis, tularemia, and Q fever. So I think about it first that way in terms of infectious agents, but then I also try and think about sites of infection. Is there something from the history or physical that points me to a location? Infective endocarditis may not point to an exact location that I can detect, but can be detectable by endocardiography. Again, also, potential occult infections in the head and neck, which you see listed there, chest, abdomen, pelvis, genitourinary tract. Musculoskeletal infections are usually more obvious because we have a sense of that by either physical exam or history. And then the possibility that this could be a CNS infection with chronic meningitis, or less likely epidural or brain abscess, because those are usually more acute presentations, but potentially in an unusual situation. So those are the infections that I try and exclude either by history or by exam or by testing as we move on through the diagnostic process. Assuming that I've done so, then the next key thing is to identify key features of what would help characterize a recurrent fever. And with that, one of the most important things is to identify fever pattern, particularly the frequency and duration, but also the features of the episode. Are the episodes similar in their presentation? In other words, the term we use is stereotypic, or are they different? Each one's a bit different than the other. That's helpful in trying to determine the cause. What's the health status between the episodes? Is the child growing and developing normally or not? Are there documented infections that have been demonstrated? Are there associated features, other physical findings, etc.? And then age of onset can also be helpful. So as we think about recurrent fever, we can divide that into several categories. And the first is there an underlying condition that is causing the recurrent fever? This isn't so common, but obviously very important to identify. Usually fever in this episode involves few or variable fever-free episodes. In other words, there's more fever than there is fever-free period. The child may be persistently unwell, even when fever-free, and may demonstrate some abnormal growth and development. What we're thinking about here is to identify those patients that might have an inflammatory disease like inflammatory bowel disease, celiac disease, an autoimmune disease like systemic juvenile idiopathic arthritis, or potentially a malignancy like leukemia, lymphoma, or neuroblastoma. Next important consideration is, well, are the recurrent fevers just really due to recurrent infection? And as I go through this, I'm looking for infections that have been diagnosed specifically by microbiology testing, or by imaging, or by a distinctive clinical feature such as varicella or bronchiolitis, which are clear distinguishable clinical syndromes, versus those that infections that might be diagnosed clinically but may not be so precise. So for instance, otitis media and pharyngitis, it's not uncommon for us to see children that have been diagnosed with those kinds of infections. I'm not quite sure that in all cases that's truly what they had, but that was the label that was attached to it. And the point of this is to identify whether the recurrent infections really are just various common childhood infections. We know that young children, particularly less than 3 years of age, can have on average one infection per month, even healthy children. And so when you're seeing a child that has that kind of history, the question is this really just recurrent infection, common infections, and nothing really more to be concerned about here? Of course, the other side of it is recurrent infections that represent something more severe, and these might be bacterial or severe viral infections or fungal infections, and may be indicative of an anatomic problem at a particular site. So for instance, recurrent pneumonia might be due to bronchiectasis from something like cystic fibrosis, or on the other hand, maybe due to an immunodeficiency as the cause of the recurrent infections. Then as we've kind of moved through those two possibilities, then the next step is to consider, does this really, if it's not likely an underlying condition or recurrent infection, does this constitute what we would call a periodic fever? These are usually fevers that last 3 days or longer. They're periodic in that they occur at some sort of interval, and that interval can be regular at a defined period of weeks, or can be more irregular. The intervals, the intervening intervals, which usually last several weeks, most often do not have fever, but can, depending upon what the cause is, and with various amounts of associated other symptoms of wellness or lack of wellness. But usually children that have something that we call PFAPA, which we'll get to in just a second, can seem entirely well in these intervening periods, which helps then to distinguish those children from children with recurrent infections or an underlying condition. Other features include, are the episodes of the illness stereotypic? In other words, do they look the same, each one the same, or are they variable in their presentation? And then are there other associated features other than just fever? What are the other potential signs and symptoms going on? The goal here is to start to then narrow down in terms of what the cause of the periodic fever is. This what we call PFAPA, or periodic fever, Aphthou stomatitis, Pharyngitis, and Adenitis. Could this be a cyclic neutropenia, less common, or also less common, a monogenic fever syndrome? We'll talk about these a bit more in the next slide. So now as we start to then classify periodic fevers, one of the first we think about is cyclic neutropenia. And the reason is because that often has its onset in the first year of life. What's notable about cyclic neutropenia is that the periods of fever and then lack of fever are usually very regular. They're oftentimes 3 weeks, almost precisely, or very close to precisely. The episodes are also stereotypic in their presentation, often with oral ulcers, sore throat, adenitis, all kind of oral pharyngeal kinds of symptoms. The thing to note is that the neutropenia precedes the symptoms. So especially in the first few or several episodes, if a CBC is done, it may not clearly identify the neutropenia if it's the CBC is done when the patient already has symptoms. Consequently, the way to diagnose these in the past has been to do CBCs 2 to 3 times a week for 6 to 8 weeks in order to be able to capture that episode of neutropenia before this and identify it before the symptoms begin. There's also genetic testing to look for a mutation in the ELANE gene. I'm told by my hematology colleagues that they are using this more frequently. Obviously, trying to do CBCs 2 to 3 times a week for 6 to 8 weeks is not a trivial undertaking, although it may be necessary if the presentation is very suggestive of cyclic neutropenia, but a mutation is not identified in the ELANE gene. Bone marrows may be done if needed, not typically needed in general, but may be necessary if there is some question about another cytopenia, and whether we need to exclude other causes of bone marrow disease. So I mentioned already what we call PFAPA, or periodic fever with Aphthou, Stomatitis, and Pharyngitis with Adenitis. The onset of this is usually 1 to 4 years of life. The episodes, again, are usually regular and around 3 to 4 weeks in between. They are also very stereotypic. Parents often say each episode looks exactly the same as the last one. They last 3 to 6 days, include the symptoms identified above. There may be some abdominal pain or other gastrointestinal symptoms, but notably, there really shouldn't be rash or arthritis, which point to other potential causes of periodic fever, which we'll discuss in a second. Inflammatory markers like WBC, ESR, CRP can be abnormal during the episode, but then normalize in between episodes. The goal of the diagnostic process here is, again, to exclude an underlying condition, differentiate this from recurrent infections or other periodic fevers, and then potentially undertake a therapeutic and diagnostic trial of prednisone, which I'll talk about in a couple of slides, which can be quite helpful in identifying the periodic fevers that really fit this kind of set of criteria. Next is the autoinflammatory diseases with fever, and this is a defined group, but sort of a mixed bag in terms of the various aspects of what they involve. So there can be a variable age of onset. There can be variable periods in terms of the recurrence of the episode. Consequently, there can be a variable number of episodes per year. The features and duration of the episode can vary. And oftentimes there's some evidence of inflammation, either of the skin, so a dermatitis, the lymph node, adenitis, and the eyes, conjunctivitis, uveitis, the serosa, so coverings of the pleura and the peritoneal membranes can get involved, causing chest or abdominal pain, and arthritis is manifested in the joints. The inflammatory markers are elevated during an episode and may remain at least somewhat elevated in between episodes. Since they have a genetic origin, there may be a family history, and really the most efficient way to start to diagnose these, aside from characterizing them, is to proceed to gene testing. So this slide shows some of the common autoinflammatory disorders with fever and the genes involved with their key features. There's familial Mediterranean fever, which I'm sure you're familiar with, involving the MEF-B gene. These episodes of fever typically are shorter, 1 to 3 days, can involve intense chest and abdominal pain due to the serositis, abdominal pain such that patients may go to the emergency department due to concern for appendicitis. But also arthritis can be seen. The next is the tumor necrosis factor receptor associated periodic fever syndromes, or TRAPS. This involves the TNF receptor superfamily 1A gene. This illness typically involves longer episodes of fever, at least 7 days and sometimes as much as 2 weeks. There's often myalgias, migratory rash, and periorbital edema. The mevalonate kinase deficiency, or hyperimmune immune globulin D syndrome, includes mutations to the MVK gene. Onset is usually in the first year of life, can involve gastrointestinal symptoms, cervical adenitis, Aphthou, stomatitis. And then finally, the cryopyrin-associated periodic fever syndromes, or CAPS. There's at least 3 of these, all involving mutations involved in the NLRP3 gene, and can present with an urticarial rash, eye findings as listed, and sensory neural hearing loss. I show you this, which comes from a publication in 2019. This is a group of international researchers that looked at what's called the Eurofever registry, which is a registry of patients with autoinflammatory diseases. The group is the Paediatric Rheumatology International Trial Organization, or PRINTO, and they developed this classification criteria for autoinflammatory recurrent fevers. The intent of this is to facilitate further research. It's not necessarily intended. In fact, the authors say it shouldn't be used for diagnosis of individual patients because they can present perhaps in somewhat different ways. It's really to try and characterize these enough in terms of the symptoms so that patients can be categorized effectively in order to do further research. And as you see, the group at the top involves identification of the specific gene abnormality associated with each of the autoinflammatory conditions, as well as some associated common clinical findings that are characteristic. There's another category of situations where the confirmatory testing does not confirm the genotype, but the signs and symptoms are still characteristic enough to categorize patients this way. And as you see, at least in their work, this first study, these categorizations had good sensitivity and specificity. And I mention this because hopefully in another 5 or 10 years, we'll understand these conditions better, not only to diagnose them more effectively, but also treat them more effectively too. So I'd like to mention just a little bit about PFAPA, because I mentioned that a trial of treatment can be actually helpful from a diagnostic standpoint. So when we approach this, we talk to the family and try and understand how much the disease is affecting the family and school attendance, etc., and really try and help decide what works best for that family as a shared decision-making model. And sometimes it's just to continue on with symptomatic treatment because the child is not that affected, the family is not that affected, and preference is not to do anything more that's not needed. A second approach is to use an episodic glucocorticoid, and what we use is either prednisone or prednisolone at a dose of 1 to 2 milligrams per kilo per dose. And a dose is given at the very onset of the fever and then to observe for resolution. If the fever, which is usually quite prompt, and that's why it's helpful diagnostically. So you take a 3 to 6 day illness and you turn it into a 12 to 24 hour illness with 1 dose of glucocorticoid. If the fever recurs, it's okay to repeat a second dose if the first dose was only 1 per kilo. If the fever persists for more than 48 hours, other symptoms develop, then obviously may need to consider another diagnosis. With some experimentation with this, you try and usually identify the lowest effective dose and warn parents that intervals between the episodes may shorten with the use of the glucocorticoid. In situations where that hasn't been successful, patients can go to tonsillectomy, which can be helpful in reducing the episodes. Prophylactic treatment can be added in addition to the episodic glucocorticoid treatment, either with colchicine or cimetidine. Of course, might be time to investigate another diagnosis. Maybe this isn't really a recurrent fever. And in some situations, some rheumatologists use anakinra. Now, as we've gone through this, obviously you can see this is not, this is somewhat of a complex process. It does not just involve infectious disease, so I don't do this on my own. We have a multidisciplinary clinic for evaluation of recurrent fever at Mayo Clinic Children's Center, which includes consultation with both pediatric infectious disease and pediatric rheumatology. For individual cases, we will obtain additional consultation with hematology, oncology, gastroenterology, immunology, and genetics, with other evaluation as indicated, such as testing for the less common infections I discussed, a more detailed immunologic evaluation to exclude immune deficiency, and then genetic testing for monogenic fever syndromes. So I am sorry that I am not there in person to take your questions directly, but here is my email address, and I'd be happy to answer any questions by email. Again, thank you very much.